Our paper today is the lead integrity alert algorithm decreases inappropriate shocks in patients with Sprint Fidelis ICD lead fractures. The Sprint Fidelis ICD lead is prone to fracture, as all of us now know. The majority of these fractures involve the pace sense conductor, and inappropriate shocks are the most common sign of pace sense conductor fracture. The lead integrity alert algorithm, or the LIA, was released by Medtronic in August of 2008 as a RAMware download to Medtronic ICDs. The purpose of this new algorithm was to improve early detection of pace sense conductor fractures and to decrease the incidence and number of inappropriate shocks. The lead integrity alert algorithm is available only in Medtronic pulse generators. It evaluates the impedance of the pace sensor conductor. It performs daily measurements, and the alert thresholds are set according to the patient's individual impedance trend. What's new in this algorithm is also the addition of noise detection, and it includes two noise detection components. One is the Sensing Integrity Counter, or SIC. It stores cumulative number of non-physiologic short RR intervals specified as more than 30 intervals less than 140 milliseconds within a 3-day moving window. The second is the non-sustained tachycardia log. It stores episodes of greater than 5 sense events, less than the VT detection cycle, and the length of the number of intervals to detect. The NST becomes positive or is triggered when 2 episodes with cycle lengths less than 220 milliseconds are seen within 60 days. Once the lead integrity alert is positive or activated, the audible alert is triggered, and it then recurs every 4 hours. It's unlike the previous algorithm where the alert only sounded at 8 a.m. In addition to the audible alert, the number of intervals to detect a tachyarrhythmia is increased to 30 of 40. And the purpose of this is to reduce the likelihood of transient noise resulting in inappropriate shocks. The objective of our study was to assess the effectiveness of the lead integrity alert algorithm in warning patients of Sprint Fidelis pace sense conductor fractures and for decreasing the incidence and number of inappropriate shocks. The study population consisted of our patients, 461, with Sprint Fidelis ICD leads and Medtronic ICD pulse generators that were implanted and followed at the Minneapolis Heart Institute. 16 Sprint Fidelis leads, including 3 failed leads that were used with non-Medtronic ICD pulse generators, were excluded. The follow-up protocol, patients were evaluated every 3 to 4 months in the clinic or via remote monitoring. Audible alerts were routinely used until evidence of increased failure was seen. The LIA was downloaded in all devices after the software was released in August of 2008, and patients and often their families were educated regarding the audible alert, and the tones were demonstrated in the clinic. Between September 2005 and April of 2010, 52 Sprint Fidelis leads failed. 3 of these were high voltage conductor fractures, which are not detected by the lead integrity alert algorithm. But 94%, 49 pace sense conductor fractures were seen. The vast majority were pace sense conductor fractures. The average time to fracture was 34 months. 53% of the failures occurred in leads before the LIA or the lead integrity alert algorithm was available, and 23 or 47% of failures were seen in patients who had had the LIA downloaded to their pulse generators. The average age of patients with the LIA and without the LIA are shown. There was no significant difference. There was no significant difference in gender. or the ICD indication. There were no differences in the underlying cardiac disease. This slide summarizes our experience in patients without the lead integrity alert algorithm. Notably, 18 of 26 patients without the lead integrity alert algorithm received inappropriate shocks as the first sign of lead failure. The average number per patient was 13, and the range was 2 to 54 shocks per patient, and these shocks occurred in storms. In patients without the lead integrity alert algorithm, 8 patients did not receive inappropriate shocks. In these patients, the alert was triggered by the impedance change in 6, and noise was seen during interrogation at routine clinic visits in 2 patients. Nine patients did not have the audible alert turned on. 3 patients received an alert but did not hear it or recognize it. And 6 patients did not receive an audible alert because the inappropriate shocks occurred before the impedance change. The audible alert based on impedance only was effective in only 35% of the patients who had the alert programmed on. The results were quite different in patients with the lead integrity alert algorithm. Only 4 patients received inappropriate shocks, or 17%, and they received relatively few shocks, on average 3 with a range of 2 to 6 shocks per patient. In 3 of the 4 patients, oversensing occurred very abruptly and resulted in inappropriate shocks. But the fact that the number of intervals to detect was increased to 30 or 40 prevented subsequent inappropriate shocks. 19 of our patients did not receive inappropriate shocks. The alert was triggered by noise and/or an impedance change in 16. And an impedance rise was found during a clinic visit in 3 patients. In 3 patients, 2 to 6 inappropriate shocks occurred as a single tachycardia episode seconds after noise was recorded and before the impedance increase. In 1 patient, 2 shocks occurred as 2 separate tachycardia episodes, despite the increase in the number of intervals to detect to 30 or 40. Noise was recorded in this patient 2 hours before the shocks as a non-sustained tachycardia episode or a short interval counter episode. In 19 of the 23 patients, or 83%, the alert was triggered by noise and/or impedance, and the impedance rise was seen at the clinic visit. I think we've already been over this. 5 of 6 did not immediately hear or recognize the alert and delayed clinic contact for 5 to 10 days. Noise resulted in multiple short intervals and detected non-sustained episodes. The fact that the NID increased to 30 or 40 prevented further shocks. We have 3 patients in this series where a progressive rise in impedance was seen. This was observed at routine clinic visits. There were no other signs of failure. We elected to replace these leads because 1 was pacemaker dependent, 2 had received appropriate therapy, and we had seen similar trends in patients prior to their actual fractures. And these are the impedance trends that we just discussed. So in summary, in patients without the lead integrity alert algorithm, inappropriate shocks were the first sign of failure, which was quite different in patients who had the lead integrity alert algorithm, and that was highly significant. So we concluded that the lead integrity alert algorithm forewarns most patients of Sprint Fidelis pace sense conductor fractures before they receive inappropriate shocks. The incidence and number of appropriate shocks has been reduced by the addition of noise detection to lead impedance monitoring and the automatic increase in the number of intervals to detect ventricular fibrillation to 30 or 40 when a defect is identified. The audible alert continues to be problematic for many patients, and manufacturers should improve the ability of defibrillators to automatically recognize device problems and notify caregivers without delay. Finally, and probably most important, all patients who have Sprint Fidelis lead should have monitoring by the lead integrity alert algorithm. Thank you.